I'm Dr. Keith C. Ferdinand, Professor of Medicine and Cardiology at the Tulane University School of Medicine, and today we're going to have an interview on two important studies, SONAR and CREDENCE. How are you doing?
Fine, thank you.
Why don't you tell the audience just a little bit about yourself?
Yeah, so my name is Donald Kohan. I'm Professor of Medicine in the Division of Nephrology at the University of Utah.
Very good. SONAR. I'm a cardiologist. I know about CREDENCE. I didn't know much about SONAR. Can you give me just the cliff notes?
Yeah, so SONAR was a study in type 2 diabetics, and it was looking at the effect of atrasentan, which is an endothelin A receptor antagonist, on hard renal outcomes, so a composite of doubling of serum creatinine, end-stage renal disease, and renal death. And they had a enrichment period in which patients were determined to be either responders or non-responders in terms of reduction of proteinuria, followed by a treatment period. And the long and short of it is that we saw a 35% reduction in risk of composite renal outcome.
That sounds very positive.
In the responders, yeah.
Any negatives?
Yes, there was an increase in fluid retaining events, statistically not significant but numerically higher in the atrasentan group, and this resulted in a small increase in hospitalization for heart failure, edema, and a small drop in hematocrit that was hemodilutional.
So some positive, some negative. I would suggest they need to do more study.
It's a very interesting question. It's not simply answered. I'm not sure that there will be another study with endothelin A receptor antagonists in diabetic nephropathy. It was an extremely large study, extremely costly study, and I think there will definitely be more studies with endothelin antagonists in chronic kidney disease, but I'm not sure about in diabetic nephropathy.
Okay, now we do have one study that was a home run,
Right.
And that was a study called CREDENCE. I think most of us have heard, even our cardiologists have heard about CREDENCE. Tell me about it.
CREDENCE was a much simpler study than SONAR. Basically, patients were given 100 milligrams a day of canagliflozin or placebo. All the patients had type 2 diabetes, had estimated GFRs between 30 and 90, proteinuria, and were treated for an average of about 2+ years. And the trial was stopped prematurely for positive results. They saw a 30% reduction in the relative risk of a similar composite renal outcome as SONAR, except theirs also had cardiovascular death. If you take out cardiovascular death, they saw the same result as SONAR, a 35% risk reduction.
So the hard renal outcomes were positive?
Very positive.
And even if you add the cardiovascular death, it remained positive?
Yes.
How about if you separated the cardiovascular death out?
So actually, canagliflozin reduced the relative risk of composite cardiovascular events by 20%. So that was 3-point MACE. So even if you add in the cardiovascular events, it still was a positive trial.
Now, one of the big questions with the SGLT2 inhibitors is whether or not it actually causes problems with the periphery. There was some question of leg amputations earlier.
Right.
Did you see that in CREDENCE?
Yeah, so no, it wasn't seen in CREDENCE.
But no.
Sorry. It was not seen in CREDENCE.
Got it.
However, the problem was in EMPA-REG, it was seen. And so there's a question of why is there a difference? We don't know the answer to that, but I think CREDENCE has shown that in people with chronic kidney disease, canagliflozin is a safe drug. So.
Another question that's arisen is how low can the GFR be, and an SGLT2 inhibitor is still a beneficial drug in terms of renal production? You said down as low as 30? So
CREDENCE went as low as 30. And during the trial, some patients GFR dropped below 30 and they were kept on canagliflozin. So we haven't seen the subgroup analysis yet. I'm confident it'll be out shortly, but indications are looking like canagliflozin will be protective even for people with more advanced chronic kidney disease.
Are you aware of any blood pressure benefits? We know the SGLT2 inhibitors do have a
Right.
positive blood pressure
Right.
lowering effect.
Right, there is a small blood pressure lowering effect, and it's actually very interesting that you see this blood pressure lowering effect and the renal protection despite the fact that hemoglobin A1C, particularly in the more advanced CKD patients, doesn't fall very much. So it's independent of effects on hemoglobin A1C.
Well, thank you very much. I think we've heard about two very important studies, SONAR and CREDENCE, and there's going to be much more to go with the SGLT2 inhibitors and renal disease, I'm sure.
Absolutely, absolutely. There's at least a couple more trials coming out.